Bismillahirrahmanirrahim. This is a series of lectures in which we are discussing the extracranial complications of otitis media. So we will try to cover some of extracranial complications today in this discussion. The links for previous lectures is there in the description, so you can check it out from there. And you are also requested to like, share and subscribe the channel. So one of the extracranial complications is what we call as Petrositis. So as the name indicates, it is the infection of the air cells present in the petrous bone at its apex. Petrous bone is pneumatized in about 30% of the individuals, and there are two groups of air cells which communicate with the mastoid air cell system. One is posterior tract, which is from the attic and the antrum, and this tract passes around the semicircular canals to the petrous apex. The other group is antero-inferior tract. So as the name indicates, it is from the hypotympanum. This tract passes around the eustachian tube and the cochlea to petrous apex. And this infection may pass through these cell tracts and reach the petrous apex. Pneumatization of the petrous apex, it is not a prerequisite. So alternate route of spread is through hematogenous spread, that is the thrombophlebitis osteitis. Long-standing atoria with indolent symptoms indicates Petrositis in the case of otitis media, and it can be associated with what we call as Gradenigo's syndrome, after the name of this gentleman, G. Gradenigo's. And this syndrome, it is also called as a triad, so it has got three features. The one is sixth cranial nerve palsy, and sixth cranial nerve palsy, we know that the sixth nerve which supplies the lateral rectus muscle of the eyeball, so patient will be unable to lateralize the eyeball on the affected side. Then there will be deep-seated earache or retroorbital pain patient may complain of, and persistent ear discharge will be there in spite of adequate treatment of the otitis media. Even persistent ear discharge in post-op cases of cortical mastectomy or modified radical mastectomy, one of the reasons may be that it is due to Petrositis. This Gradenigo syndrome, you must keep in mind that this is not pathognomonic of Petrositis. Rather, this presentation may be with extradural abscess at the apex as well. So any infection which is there at the apex can lead to Gradenigo's syndrome. And there can be cochleovestibular symptoms along with facial weakness and constitutional symptoms in case of acute Petrositis. So high resolution CT scan will be investigation of choice to show us the extent of the infection and the route from which the infection has traveled from the middle ear and mastoid cavities to the petrous apex. Of course, high dosage IV antibiotics, this should be triple regime, of course, and ultimate treatment is surgical exploration. And this surgical exploration, it will there are different surgical approaches to the petrous apex, and the choice of surgical approach will be dependent upon the findings of CT scan in that particular individual patient, that through which route the infection has spread to. For example, if it has gone from posterior part, then we can go through this thorn wall approach, which is through the attic after tegmen is removed, or through the arch of superior semicircular canal, or we can go between horizontal and superior semicircular canals. If it is the spread of infection is through the antero-inferior tract, which is coming from the hypotympanum, then we can go between the carotid and the cochlea, that is Remedier-Lampert approach, or we can go through the hypotympanic air cells adjacent to the round window, or beneath the posterior semicircular canal and beneath the facial nerve. As undergraduate students, you are not supposed to memorize all these different approaches, so you can simply write down in your answer sheets that there are different surgical approaches to the petrous apex, and the choice of approach will be dependent upon the findings of the CT scan of the temporal bone in that particular patient, and accordingly we will approach the petrous apex. But at the end of the day, surgical exploration is the solution of this petrositis. Another extracranial complication is very important, facial nerve paralysis, and facial nerve is so much important with reference to middle ear that we will discuss it as a separate topic. Here I have mentioned it as a so that you must memorize that one of the very important complications of otitis media is facial nerve paralysis. So very hurriedly I will go through few points regarding facial nerve paralysis, but very soon we will discuss it in detail as a separate entity. So with reference to otitis media, 3 to 5% incidence of facial palsy are due to otitis media. It is more common in children after acute suppurative otitis media, and acute onset is in acute otitis media within first week, and chronic protected course is there in chronic otitis media. Cholesteatoma, granulation tissues, suppurative labyrinthitis, petrous osteomyelitis can lead to this facial nerve paralysis. Then congenital petrous cholesteatoma can also lead to progressive palsy with long-standing severe hearing loss without atoria, because in congenital cholesteatoma we know that there is intact tympanic membrane and there is no ear discharge. Facial nerve exposed by cholesteatoma, it is very interesting, it is mostly escapes palsy because the epinurium, which is affected by the cholesteatoma, it is replaced by the matrix of the cholesteatoma. So facial nerve underlying remains intact and protected. In acute otitis media, there is neurotoxic effects due to inflammatory mediators, bacterial toxins, and it spreads through natural dehiscence at vascular channels, and a mass effect is there on the bare nerve. In contrast, in case of chronic otitis media, the underlying pathological process is osteitis, or erosion of the bone, or direct pressure, which leads to edema, and ultimately there can be neuropraxia or neurontemesis. Cholesteatoma and granulation tissues can involve the facial nerve, and acquired fallopian canal dehiscence, if it is there, even it is affected in tuberculous otitis media as well. So clinical diagnosis, it is usually very easy. CT scan is not a routine investigative procedure, but if it has to be asked for, the cuts should be less than 2 millimeter, so that proper exposure of the tympanic cavity and facial canal is available. So we have to go for again IV antibiotics, high dosages, triple regime antibiotics with the merengotomy if it is indicated, and in acute otitis media and in chronic otitis media, canal wall down procedures at least, like modified radical mastectomy with removal of cholesteatoma and granulation tissues, and facial nerve decompression by removing the matrix from the epinurium, and nerve repair if it is needed. So very briefly I have mentioned about the facial nerve paralysis, but facial nerve paralysis in itself is a huge topic, separate entity, and in addition to otitis media there are 101 causes for facial nerve paralysis. So we will discuss as a separate topic this facial nerve paralysis some other day. So with that, we come to end of today's discussion. You are requested to like, subscribe and share the channel with your friends. Thank you very much.